Hi, this is a presentation on the ultrasound diagnosis of adenomyosis. My name is Suzanne Johnson and I'm a gynecologist from Southampton. In this talk, I will be talking about the prevalence and symptoms of adenomyosis, imaging, the Musa group, the association of adenomyosis and endometriosis, a new classification system, whether something is an adenomyosis or fibroid, and a summary. Adenomyosis is usually diagnosed in women aged 40 to 60-year-old, but they can be much younger. It's caused by the growth of ectopic endometrial glands and stroma into the myometrium. It can be caused by infiltration of the external myometrium from outside the uterus. It's much more common than we think. In this paper, they showed that 1 in 5 women in a general gynae clinic had deep and/or ovarian endometriosis, and of those women, 1 in 3 had both endometriosis and adenomyosis. The symptoms of adenomyosis can include menorrhagia, potentially leading to iron deficiency anemia, dysmenorrhea, dyspareunia, menstrual bladder symptoms, pressure symptoms, back pain, bloating, and subfertility. Both endometriosis and adenomyosis can have adverse pregnancy outcomes. There are reduced pregnancy and live birth rates, an increased miscarriage rate, and various other adverse obstetric outcomes. Imaging for adenomyosis can be done by ultrasound and MRI, and in this recent meta-analysis, they showed that MRI and ultrasound are equally good. The Musa group gave us a language and a system to define different myometrial abnormalities, including adenomyosis, and they subsequently published these further papers which helped us to diagnose adenomyosis much more clearly. They described direct features such as small myometrial cysts, hyperechogenic islands, and echogenic subendometrial lines and buds, and if you see some of these features, you would say this patient has adenomyosis. But there are also indirect features which are more caused by the direct features, such as the asymmetrical thickening, a globular uterus, irregular junctional zone or an interrupted junctional zone, translesional vascularity, and fan-shaped shadowing. The Musa groups described that you could do this in 2D or 3D. And 3D, of course, enables an offline examination. You can get a second opinion from an expert. And in the multiplanar view, you can scroll through the sectional planes, and in the coronal section, look at the external contour and endometrial cavity shape in more detail. And so how do you get a 3D vaginal scan? You take a volume, and that will display as a longitudinal section, a transverse, and a coronal section. And when you render that, you then get a coronal view with which you can manipulate. And this is the coronal view. It's this purple line that divides you into a front half and a back half. So you can, on 3D, you can look at the endomyometrial junction or the junctional zone in more detail, as I've done in this image where I've rendered the coronal view, and you can very nicely see the endomyometrial junction, which is this hypoechoic line. And it is that you look for irregularities in to diagnose adenomyosis. There's now also a quicker way to do a 3D ultrasound, and that is on some of the touch screens. You can see me doing that here on a GE Swift. And you can see that just by drawing a line on the longitudinal view of the uterus, you obtain a coronal view. And again, you can look at the endomyometrial junction in some detail. So if I take an example, a patient attends clinic with pelvic pain with or without menorrhagia. The IDEA consensus has shown us how to diagnose endometriosis, and they do 4 steps, and you can do the steps in any order, but this is my order. And they start with a systematic routine pelvic ultrasound, looking for features of endometriosis, including uterine adenomyosis. The scan assistant on the GE machine also does this. It uses the 4 steps, 1, 2, 3, 4. And the first step, again, is adenomyosis. And there are some images as an example to help guide you to diagnose this. There are also images of the other deep endometriosis lesions. So the idea, step one, is the systematic pelvic scan. The first thing we look for is the uterus. Now, this uterus is anteverted and retroflexed, and it's retroflexed. It's the fundus is being pulled toward the patient's feet because there are adhesions at the back of the uterus, pulling the uterus into a question mark sign, and that was described by Nadine Donato in 2015. Next, we will look for the presence of adenomyosis, and in this example you can see that this is a very bulky globular uterus with small myometrial cysts, stripy shadowing, and a very indistinct endomyometrial junction. You really have to look very carefully to see where is the endometrial cavity, and measuring the ET can be very difficult. Adenomyosis can look like this, where you have islands of endometrium in the myometrium, and you can see that very clearly in this case with severe adenomyosis. And on 3D you can see here that you've got a very irregular endomyometrial junction. There isn't that nice clear dark line that we saw in the original example. This is budding into the myometrium, and it looks to be almost invading it. This is another example of adenomyosis creating an unequal wall thickness. The posterior wall is much thinner than the anterior wall. With translesional vascularity, when we've got this adenomyosis here with color Doppler, you can see that there isn't a peripheral vascularity like a fibroid, but the vascularity goes through the lesion. And then here you can see this stripy shadowing because you've got little cysts in the myometrium, and that's why you get this stripy shadowing. So here's another video example of a case with severe adenomyosis. So again, the endomyometrial junction is very indistinct, and you can see cysts in the myometrium, these hemorrhagic cysts, and you can see islands of endometrial tissue in the myometrium. And you can see when I put some color on, the vascularity extends through the lesion. It's not a fibroid. And on 3D, remember that was the nice endomyometrial junction in the coronal plane, nice and clear. But in this example, you can see that the endomyometrial junction has been completely disrupted, and that here is one of those little myometrial cysts. So 3D is extremely useful for diagnosing adenomyosis. You can also get adenomyosis after septal surgery or after an endometrial ablation, and you wonder about the role of retrograde menstruation in cases like this. The other thing that you must consider is if you've just diagnosed adenomyosis, is there also endometriosis? And again, going back to the IDEA classification, in this case, I was diagnosed adenomyosis. We can see these islands of endometrial tissue in the myometrium, a very disrupted endomyometrial junction on 3D, and then also an ovarian endometrioma, a bowel nodule, and some deep endometriosis in the ligaments. And I'll just show you that on a video clip. So adenomyosis, an ovarian endometrioma, bowel nodule, and ligament deep endometriosis. And the association between adeno and endo is very common. So can we classify adenomyosis a bit better? There's a lot of research being done in this, and this group published this system. So we're not going to be using this in every time we do a scan, but it just helps us to recognize better what we're looking at. So once we've diagnosed adenomyosis, it is very useful to be able to say whether it's focal, and if it's focal, if it's an adenomyoma, or diffuse. So focal or diffuse, these are useful things to be able to put in the report. And the main thing, as we said before, the direct features are the subendometrial lines, the subendometrial buds, and these hyperechoic islands. These are the three direct features of adenomyosis. But we can then say, is it focal or diffuse? And the definitions are, if it's focal, that more than 25% of the lesion is surrounded by normal myometrium. If it's diffuse, less than 25% of the lesion is surrounded by normal myometrium. You can see just a little bit here and a little bit there. And an adenomyoma is focal adenomyosis demarcated by hypertrophic myometrium, but not a capsule. It's not a fibroid. It won't peel out easily, but it's just an ultrasound appearance. So useful to say, can we see direct features, and is it focal or diffuse? So in focal, I'm sorry about this, you don't have to remember it all, but there are 5 kinds of focal adenomyosis. There's type 1, which is the focal adenomyosis in the outer myometrium. I'll show you some examples. 2 and 3 is what we've been talking about, the subendometrial lines and buds and the echogenic islands. The 4th type is a macrocystic appearance of adenomyosis, and 5 is an ACOM. So I'm going to go over these one at a time. Focal adenomyosis in the outer myometrium is where you've got some nodules in the anterior or in the posterior compartment, and they invade the uterine serosa, the outer myometrium, and there are examples in the paper of that here. But I'll show you an example in the posterior compartment in this patient. She was 38, she'd had severe dysmenorrhea since she was 16. She would nearly pass out during a period and was sometimes admitted to hospital. She had dyschezia, so pain on opening her bowels during a period, nulliparous, and no surgery. You can see here this uterus is a bit anteverted and retroflexed, and when we look, and this area is the torus where the uterosacral ligaments attach. If we look at this area in a little bit more detail, there's the internal os, there's the torus. Here you can see a nodule of deep endometriosis in the ligaments, but it's invading the outer myometrium. And you can see that more clearly in this image here, where you can see that the echogenicity of this bit of myometrium has become altered because this nodule in the ligaments is invading the myometrium. And so in the report we would say this is a bulky anteverted retroflexed uterus. There was a little bit of diffuse adenomyosis, but she had a large nodule of deep endometriosis at the torus invading the myometrium, causing superficial adenomyosis, and it was contiguous with a stenosing bowel nodule here. And you often find that the association of superficial adenomyosis and ligamentous and bowel nodules in the posterior compartment, that they run together. And here's a little video clip of that, and you can see it in a little bit more detail. There's the bowel nodule, this very dark hypoechoic nodule. There is white retrocervical fibrosis. Here is the nodule in the deep ligaments, and you can see the echogenicity of the myometrium has become altered by this superficial adenomyosis. You can also have this in the anterior compartment, so there's the bladder and there's the uterus. There's a nodule of superficial adenomyosis. It's not a bladder nodule of deep endo, the overlying muscularis is normal. And this is a rendered view on 3D in the transverse, and you can see it's clearly that the muscularis is normal, the mucosa is normal, but this is a nodule of deep endometriosis that in other views was contiguous with the uterus. This is what we've already talked about. This is the normal, if you like, focal adenomyosis, the subendometrial lines, buds, islands, with or without cysts. And as an example here, this patient was 52 and came with irregular bleeding on HRT with a thick endometrium at 6 millimeters. And here you can see that this is a retroverted uterus. It is bulky. There's nothing obvious. The endometrial thickness was in fact normal. But in the transverse view, you can see an island of endometrium in the myometrium. And if I show you this video clip, you can see tiny little cysts at the endomyometrial junction, and this little bud there. There's that little cyst. So this is minor focal adenomyosis, and you've got to go looking for the deep endometriosis because it's not going to be that obvious. But there is a nodule of deep endometriosis in the left uterosacral ligament. It's always slightly harder in a retroverted uterus, but there is the deep endometriosis, and this is where the minor, this is in the transverse plane now, the minor focal adenomyosis. The 4th type is this macrocystic lesion. This again is a retroverted uterus, and you can see here this big cystic adenomyoma. These macrocysts are usually more than 10 millimeters. This one was 35 millimeters. They have an echogenic rim and hemorrhagic content, so ground glass appearance. Focal adenomyosis. And then the 5th type is an ACOM, an accessory encavitated uterine mass. They used to be called juvenile adenomyomas, and we've gone to ACOM, and now it's being reclassified as focal adenomyosis. And it's a unilocular cyst lined by functional endometrium. and it's a Müllerian abnormality with some duplication of tissue at the insertion of the round ligament. So it's always in the same place, just below the interstitial portion of the fallopian tube. But the rest of the uterus will be normal on 3D, and that helps you to distinguish it from a unicornuate uterus with a rudimentary horn. So this, in this slice, looks unicornuate. It wasn't. This was a normal triangular shaped cavity, and then this acum on the side. And I'll show you this example. This girl was 18, had constant pelvic pain. She was completely cured by surgery. In the transverse plane, you can see here that on the left side there is this cyst. Clearly it's blood filled, it's got endometrial tissue within it. This is in the longitudinal plane, and on 3D you can see that that is where this adenomyoma, again, that looks unicornuate in this bit, but if I rotated it slightly, otherwise it was just a bit arcuate. But this was an acum, and at laparoscopy, just underneath the insertion of the round ligament was this acum, and that was removed, and the girl had no further symptoms. And this is an excellent paper describing acums in a lot of detail. So a summary of adenomyosis is that we have a classification and reporting system, that the direct features of adenomyosis are the subendometrial lines, subendometrial buds, and hyperechogenic islands, the direct features. The direct features are then in association with indirect features, causing maybe a globular uterus, fan-shaped shadowing, and translesional vascularity. We can then think about, is the adenomyosis, is it focal, is it diffuse, or is there an adenomyoma? And we can subcategorize it further into superficial adenomyosis, a macrocyst, or an acum. The last thing to say is that there is a difference between fibroids and adenomyosis. Of course, they can coexist. So the difference between a fibroid and adenomyosis is that the fibroid, if in this case, let's say it's intramural, this would be closer to the cavity usually, but that's not a huge difference. The shadowing behind a fibroid tends to be more like block shadowing, whereas it's stripy behind adenomyosis. And then you get vascularity surrounding the lesion in the fibroid, where the vascularity just goes straight through the adenomyoma because there isn't a capsule, and I would set my PRF at 0.6. When they coexist, you can see in this example, this is a retroverted uterus, and here is a little fibroid. It's hypoechoic, it's got a regular outline, it's got some peripheral vascularity. But on the other side was this area of altered echogenicity with translesional vascularity, and it's more obvious in a minute on 3D. There is the fibroid, and here is the endometrial cavity, and you can see that this area is hyperechoic and mixed echogenicity. And on the video you can see it much more clearly. That's obviously a fibroid, and here you've got a very difficult to see endomyometrial junction. You've got little cysts, you've got hyperechogenic little islands, and this is an area of focal adenomyosis and a fibroid coexisting. And in this example, similarly, you can see this is a transverse pass through the entire uterus. I like to go up and down a few times. The transverse plane is often extremely useful, and you've already spotted, of course, the adenomyosis and the fibroid. And this is when I did a 3D on the trace system that I showed you earlier, and you can immediately see there's the fibroid, there's the adenomyoma. Fibroid, adenomyoma. So 3D, jolly useful. So in conclusion, adenomyosis is very common. It can be very symptomatic, and there can be fertility consequences. Adenomyosis is a sister condition of endometriosis, and diagnosing adeno is really important because we can decide how to manage these patients both medically and surgically, if they've got adenomyosis, we need to look for coexisting endometriosis. So thank you very much. This is a QR code to my YouTube channel, and there's lots more videos on there on diagnosing adenomyosis, endometriosis, Nexal cysts, etc. Thank you very much.